Occupational English test. Listening test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Hello, are you Mr. Thompson?
Yes, that's me, Doc.
Great, nice to meet you, Mr. Thompson. I see you're here for some persistent headaches.
Yes, Doctor. It's been going on for a couple of weeks now.
Can you describe the headaches for me? Are they localized to a certain area or more of a general headache?
They're localized. The pain is mostly around the temples.
On a scale of 1 to 10, how would you rate the pain?
I'd say it's usually around a 7. Sometimes it goes up to an 8 or 9.
Have you noticed any other symptoms accompanying the headaches, like sensitivity to light or nausea?
No nausea, but definitely some sensitivity to light. It's hard to be in a bright room when it happens.
Do you have a history of migraines in your family?
My mom used to get them pretty bad.
I see. Have you experienced any changes in your vision?
Not really, no.
What about your stress levels? Have you been under a lot of stress recently?
Well, my job has been a bit demanding lately, but it's nothing out of the ordinary.
Are you currently on any medications?
Just some over-the-counter pain relievers for the headaches.
I'm concerned about your symptoms, especially given your family history and the intensity of your headaches. Although stress can certainly be a factor, it would be wise to rule out other potential causes.
So what's the plan, Doc?
Firstly, I'd like to get some blood tests and an MRI scan of your brain to rule out any underlying issues. I'll also refer you to a neurologist for a more specialized evaluation.
Sounds good. Anything else?
For now, let's start with that. Depending on the results, we'll determine the next steps. It could be that you're suffering from migraines, but we won't know for sure until we've conducted a thorough investigation.
Understood. Thank you, Doctor.
You're welcome, Mr. Thompson. Let's get you feeling better.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Hello, Mrs. Johnson. Thank you for coming in today. I see here that you were referred to the pulmonology department by your primary care physician.
Yes, that's correct, but please call me Emily.
Of course, Emily. What prompted you to visit your primary care doctor in the first place?
I've been experiencing some shortness of breath for the past couple of weeks. At first, I thought it was anxiety or stress, but it's become a daily occurrence.
Are you experiencing any other symptoms along with the shortness of breath?
Yeah, I've had a persistent cough, and sometimes there's a wheezing sound when I breathe.
When did you first notice these symptoms?
I guess it started around 3 weeks ago.
Is the shortness of breath and wheezing consistent, or does it come and go?
It seems to get worse at night. I've also noticed it's worse after I exercise.
Okay, have you noticed any triggers? For example, are you around any allergens like dust or pets when this happens?
I do have a cat, but I've had her for years, and this has never been a problem before.
Now let's talk about your medical history. Have you had any surgeries, or do you have any chronic conditions?
No surgeries, but I do have high cholesterol and take medication for it.
And what medication are you currently on?
I take statins for the cholesterol. Other than that, just some multivitamins.
All right, you don't appear to be at risk for medication-induced lung issues. On examination, I noticed some wheezing upon auscultation. I'd like to order a few tests, a complete blood count and a chest x-ray to start with. Depending on the results, we may also do a pulmonary function test.
Wow, that sounds like a lot. What are you thinking?
Given your symptoms, we need to rule out a variety of potential causes. It could be something like asthma, given the wheezing and exercise-induced symptoms, or it could be something else affecting your lung function. The tests will give us a clearer picture so we can proceed with the most effective treatment.
Okay, sounds good. When should I expect the results?
Usually within a few days for the blood work and x-ray. If we proceed with a pulmonary function test, that may take a bit longer to schedule.
All right. Thank you for explaining everything.
You're welcome, Emily. Once we have the results, we'll have a better idea of how to improve your quality of life.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Dr. Smith, I have a patient with a recurring urinary tract infection that I'd like to discuss with you.
Yes. I saw the patient's chart earlier. What seems to be the issue?
Well, the patient has been on several rounds of antibiotics over the last 6 months, but the infection keeps coming back. I'm concerned about antibiotic resistance.
That's a valid concern, especially given the patient's history. Have you considered running a sensitivity test?
Yes, we've done that, and the results were inconclusive. What would you recommend as the next steps?
In cases like these, it might be helpful to explore other treatment options like intravenous antibiotics or consult an infectious disease specialist. It's crucial to ensure we're not contributing to antibiotic resistance by prescribing the wrong medication.
Now look at question 26.
In today's session, we'll discuss the various treatment modalities for major depressive disorder. The first line of treatment is usually a combination of psychotherapy and pharmacotherapy, such as SSRIs or SNRIs.
That's right, and it's important to mention that medication alone is often not sufficient for long-term management.
Exactly. Cognitive behavioral therapy, or CBT, is often employed alongside medication, but there are other types of psychotherapy like interpersonal therapy and dialectical behavior therapy that could also be effective.
And what about treatment-resistant depression? I know that can be a real challenge to manage.
Absolutely, and that's when other treatments like electroconvulsive therapy, ECT, or transcranial magnetic stimulation, TMS, could come into play. These are generally considered for severe cases where other treatment modalities have failed.
Very true. And let's not forget the role of lifestyle changes, like diet and exercise, in mental health treatment.
Certainly, a holistic approach is often the most effective, but it's crucial to tailor the treatment to each patient, as mental health is not a one-size-fits-all issue.
Now look at question 27.
We've noticed some inconsistencies in how blood tests are being documented, so I want to cover what exactly needs to be included in our documentation. First, always note the date and time of the sample collection, as well as the indication for the blood test. Was it routine screening? Was it to monitor medication levels? That needs to be clear. Then comes the results, which must be entered meticulously. Here, it's crucial to highlight abnormal levels and compare them to the previous results, if available. If there are any flagged indicators, like elevated white blood cell counts or lowered hemoglobin, those need special attention. Finally, you'll record your impressions and recommended next steps. Are further tests needed? Is a change in treatment warranted? These plans need to be explicit and actionable. I've provided a guide with examples for everyone to review. Make sure your documentation is thorough. Sloppy documentation can lead to diagnostic errors and can waste everyone's time.
Now look at question 28.
As we've seen some lapses in communicating effectively with patients about pain management, I'd like to remind everyone of the utility of the PQRST method for assessing pain. The P stands for provocation. What brought the pain on? Q is for quality. What does the pain feel like? R is for radiation. Does the pain move anywhere? S is for severity. On a scale of 1 to 10, how bad is it? And T is for timing. Has the pain been constant, or does it come and go? Asking these questions not only gives you a comprehensive understanding of the patient's pain, but also makes the patient feel heard and involved in their own care. I can't emphasize enough how vital clear communication is in pain management. Your dialogue with the patient will often guide your treatment choices. You might uncover that the pain is not just physical, but has emotional or psychological components, necessitating a more holistic approach. I've prepared a checklist that uses the PQRST method for you all to practice with.
Now look at question 29.
So, I had a look at the patient you referred to me who has been struggling with high blood sugar levels. The HbA1c levels are sitting at 9%, which is quite above the target.
That is concerning. They are on metformin and have been trying lifestyle modifications.
Yes, I saw that. But given the persistence of high HbA1c levels, lifestyle changes and metformin alone are insufficient. I'm considering adding a GLP-1 receptor agonist or perhaps a basal insulin regimen to better control the glucose levels.
I see. I'll be meeting with the patient soon and we'll discuss these options.
Great. We really need to bring those numbers down to prevent complications. I'll send you my full report and recommended treatment adjustments.
Now look at question 30.
I've been reading hospital safety reports, and it's alarming to see how many medication errors occur because of miscommunication or lack of double checks.
Yeah, I've noticed that too. We were taught the 5 rights of medication administration. Right patient, right drug, right dose, right route, and right time. But sometimes it feels like people are rushing and not double checking.
Absolutely. Another issue is the look-alike, sound-alike medication names. We really have to be cautious and perhaps read back the medication name and dose to a colleague as a second check.
Good point. In a busy ward, these checks can be life-saving. I think it's time to revisit our protocols to ensure that we're all adhering to best practices.
Agreed. Let's bring it up in the next staff meeting. It's better to spend a few extra moments verifying than to deal with the consequences of a medication error.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Welcome everyone. My name is Dr. Smith. In previous sessions, we've discussed various life support modalities such as mechanical ventilation and continuous renal replacement therapy. Today, we're diving deep into a fascinating yet complex topic, extracorporeal membrane oxygenation, better known as ECMO. ECMO is a form of life support that can take over for both the heart and the lungs, usually considered when other treatments have proven to be ineffective. ECMO is mainly used in two scenarios: veno-arterial, VA ECMO for heart failure, and veno-venous, VV ECMO for respiratory failure. Each has unique indications and contraindications, so it's vital to understand when and how to deploy them. Firstly, veno-arterial ECMO is essentially a form of mechanical circulatory support. It's useful in situations such as cardiogenic shock, post-cardiotomy failure, or even as a bridge to transplant. Remember that VA ECMO can support both the cardiac and respiratory functions, but it can also impose significant afterload on the left ventricle, potentially worsening heart failure if not managed carefully. Veno-venous ECMO, on the other hand, is used for isolated respiratory failure conditions like ARDS or acute severe asthma. It's vital to note that VV ECMO won't support circulatory failure, so your patient needs to have a relatively stable cardiovascular system to be a good candidate. Advantages of ECMO include complete cardiopulmonary support and the ability to give the native heart and lungs a chance to recover. However, ECMO is fraught with challenges, such as the risk of bleeding, infection, and limb ischemia, to name a few. Additionally, the technical skills required to manage an ECMO circuit should not be underestimated. The initiation of ECMO should be performed only in specialized centers with multidisciplinary teams experienced in its use. Always remember, ECMO is a team sport that involves surgeons, intensivists, specialized nurses, perfusionists, and pharmacists. Speaking of pharmacology, it's crucial to realize that patients on ECMO often require adjustments in medication dosages due to changes in pharmacokinetics and pharmacodynamics. For example, these patients might need more aggressive anticoagulation to prevent clotting within the ECMO circuit. Before ECMO initiation, the patient should be adequately sedated and paralyzed to prevent dislodgement of tubes and catheters. After you've identified a candidate and prepared the patient, the cannulation process begins. Cannulation can be either percutaneous or surgical and should ideally be guided by ultrasound to reduce complications. In summary, ECMO is a highly specialized form of life support that has saved many lives, but also comes with its unique set of complications and considerations. Just like with suturing techniques, mastery of ECMO requires thorough understanding and practical experience. So in our next session, we will work through some ECMO simulations to better understand the mechanics of setting up and managing an ECMO circuit. I hope this provides an informative overview of ECMO. Thank you, and I look forward to seeing you in our next training session.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Welcome to today's segment of our series on groundbreaking healthcare innovations. I am delighted to introduce Dr. Jennifer Smith, a pioneer in the field of CRISPR technology, which has changed the face of genetic engineering. Welcome, Dr. Smith.
Thank you. It's a pleasure to be here.
Your work in CRISPR is revolutionary, but what drove you to enter the realm of genetic engineering in the first place?
I've always been interested in the complexity of life at the molecular level. Early on, I became fascinated with genetics, the idea that our lives are dictated by codes within our cells. I wanted to understand how those codes work and how we can potentially rewrite them to solve major health issues.
Incredible. What led you to focus specifically on CRISPR technology?
During my postdoc years, I realized that traditional genetic engineering methods were time-consuming and imprecise. When I first learned about the CRISPR-Cas9 system, a naturally occurring defense mechanism in bacteria, I was captivated by its potential to make gene editing faster and more accurate.
For those unfamiliar, could you briefly explain what CRISPR is?
Certainly. CRISPR stands for Clustered Regularly Interspaced Short Palindromic Repeats, and it's essentially a tool that allows us to cut and paste genes. Imagine you have a document with a typographical error. CRISPR is like using the find and replace function to correct that error in the genetic code.
Remarkable. How did you approach your research given the ethical concerns surrounding gene editing?
Ethical considerations have been a part of the dialogue since the beginning. My team and I work strictly within the existing guidelines and focus on somatic cells, which are non-reproductive, to mitigate the risk of unintended consequences. For example, we are particularly interested in using CRISPR to treat diseases like cystic fibrosis or Huntington's disease.
What successes have you witnessed in applying CRISPR technology to healthcare?
One of the most promising applications has been in the realm of cancer research. We've successfully edited genes to make cancer cells more susceptible to chemotherapy, thereby increasing the efficacy of the treatment. We're also exploring CRISPR as a potential cure for genetic conditions like sickle cell anemia.
How has the healthcare community reacted to these advancements?
The medical community is incredibly excited, but also cautious. The potential for CRISPR to revolutionize medicine is enormous, but we need to move carefully to ensure the technology is safe and ethical.
Given that this technology could potentially alter the human genome for future generations, what steps are being taken to ensure its ethical use?
There's ongoing debate and discussion within the scientific and ethical communities about the appropriate uses of CRISPR. A global moratorium on editing germline cells, which are cells that could pass edits to future generations, has been widely supported. The focus right now is on treating diseases and conditions in a way that won't affect future generations.
It sounds like a transformative but carefully guarded frontier. Thank you for sharing your insights, Dr. Smith.
You're welcome. It's a field with so much promise, and I'm excited to see where it takes us.